Good morning, everyone. My name is Dr. Rob Murphy. I'm the Executive Director of the Havey Institute for Global Health. I'm also a Professor of Medicine and Biomedical Engineering and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. Thank you for taking the time to join us today for the 10th Annual Global Health Day of the Havey Institute for Global Health. This event is an exciting opportunity to draw together our global health researchers throughout our network, including researchers, basic researchers, educators, trainees, and students to celebrate and discover more about global health research, education, and outreach efforts throughout our Northwestern system. We're going to begin the day shortly with breakout sessions. There are no specific topics for the session. It's a mixture of presentations with about 6 or 7 per session. You'll hear more about the sessions in a second. And then after that, promptly at 10:15, we will return to this main room and we will have 2 plenary sessions. The first one is going to be led by Dr. Maria Oden and Queen Dubé. And they will discuss the multi-institutional initiative called NEST 360. So NEST was a newborn essential solutions and technologies to reduce neonatal mortality in sub-Saharan Africa. It's an incredible program. You're going to hear about it. We are part of that program, actually, here at Northwestern. This will be followed by a presentation by Dr. Louis Pizero, who's at Untitled at WHO, and he's going to talk about equitable access for innovation in global health. That will be followed by a closing ceremony. While we're unable to, unfortunately, to gather in person this year, we're thrilled for the opportunity to engage with all our global health affiliates, partners, community members in this virtual format. And now I want to introduce the actual Dr. Robert Havey. He's the deputy director of the Havey Institute, named in his honor, and he's going to say a few words. Bob?
Great, thank you, Rob, and hello, everybody. My name is Dr. Bob Havey. I'm the deputy director of the Institute for Global Health. I'm also a clinical professor of medicine at Northwestern's Feinberg School of Medicine. As Rob said, almost embarrassingly enough, the Institute was named after me in my honor by a generous family endowment gift. It's really not an expression of one person. It's really an expression of the belief of many people not in medicine who understand the critical importance of global health research, education, clinical care, that have really kind of helped fund a lot of our activities and helped our growth. Those who followed this Global Health Day for the last 10 years probably are impressed when they go to our website and see how much we've grown, and that's because of the great team and the dedication of everyone on the line here and a lot of the judges for the breakout sessions that you'll meet today, and it's the reflection of the generosity of a lot of our supporters. We established over the years, educational outreach programs, supported clinics where our medical trainees and faculty work. We provided seed funding for research and worked closely with faculty across our medical campus and across the world to support efforts in global health. Each year on Global Health Day, we're able to highlight the incredible work and research of our faculty, students, and partners. I'm happy to share that today we'll be hosting 49 presentations, 39 of which were submitted by trainees or students, representing work being done in 20 countries. I'd now like to invite our Administrative Director, Kate Klein, to give an overview of the day. Thanks.
Thank you so much, Dr. Havey. Hello, my name is Kate Klein. I want to welcome you all to today's event. Before I begin, I would like to acknowledge 2 people whose hard work really made today possible. Sarah Cadillo and Kristen Weber, thank you so much for everything you did to make today possible. Today we'll begin our event with our live presentation breakout room sessions, all of which will be recorded. There will be a total of 8 breakout rooms for attendees to join. Attendees will shortly be placed in breakout rooms at random. However, you're welcome to travel freely between the breakout rooms as you wish by selecting the More area at the bottom right of your screen and then selecting Breakout Rooms. If you have any technical issues, please feel free to return to the main room and to chat the event host, Kristen Weber, for assistance in joining a specific breakout room. Room assignments will be displayed in the main room throughout the session as a point of reference. The poster session will be ended promptly at 10:15, at which time we will gather together back here in this main room for our 2 plenary presentations. Thanks to all that have joined us today. And at this time, we'll begin with our breakout room placements, and we appreciate your patience as we look forward to this wonderful event. Thank you so much.
Welcome back, everyone. Thank you very much, and thank you who just joined us. We just finished up the poster session, which actually went very smoothly. I'm very pleased today to introduce our first speakers in our first plenary session. Maria Oden, PhD, and Queen Dubé, medical doctor, are the presenters for this first presentation. Maria is the co-director of Rice 360 Institute for Global Health and director of the Oshman Engineering Design Kitchen at Rice University. She has 25 years of combined academic research and clinical experience in biomedical engineering and engineering design. And this solid background has been foundational to her leadership in biomedical engineering and the use of engineering education to teach students to identify, innovate, and build devices and technology that solve real-world problems, which you're going to hear all about this. Queen Dubé, Dr. Queen Dubé, serves as the Chief of Health Services of the Ministry of Health in Malawi. She's a consultant pediatrician and clinical epidemiologist. Prior to her appointment as Chief of Health Services for Malawi's Ministry of Health, she was the head of the Department of Pediatrics and Child Health at Queen Elizabeth Central Hospital, the largest tertiary hospital in Malawi. Dr. Dubé has worked with the Ministry of Health, Saving Newborn Lives, WHO, Pediatrics and Child Health Association of Malawi, and UNICEF to improve the quality of newborn care in district hospitals and to improve the quality of care for the small and sick newborns in Malawi. Both Drs. Oden and Dubé serve as co-principal investigators on the NEST 360, which you're going to hear about, which also Northwestern plays a role with the Carapel Mountain, and which is an international alliance of clinical, technical, and public health experts from 15 leading institutions, governments, and organizations with the initiative to cut in half the neonatal mortality rates in Africa. There will be time for a short Q&A following the presentation, and we welcome you to submit questions to the event host through the chat feature, please. There's too many people on for people speaking, so put your questions in the chat at any time during the presentation. Okay, Maria and Queen, I now turn it over to you.
Thank you so much. And I'm going to echo what Rob said, which is what we're going to talk about is a collaboration amongst experts all around the world, and Northwestern and colleagues from Northwestern are such an important part of this collaboration. Queen and I are just here representing this amazing group of experts working together. Let's see here, sharing my screen.
Can I ask one thing? Why, go ahead and share your screen, but if you're showing your video, could you turn your video off during the presentation? Thank you.
Sure. Thank you so much. So we have divided this talk into a couple of different sections, and Queen is going to start us off. And Queen, I'm controlling the slides and I'll try to keep up with you, but if you need me to do anything differently, just let me know.
Thank you, Maria. You put it in slideshow, please.
Are you not seeing the slide?
No, it's not in slideshow.
Yeah, we're seeing the slides, but not in the slideshow format.
Huh,
You know, it has your whole
yeah, I just tried that. So let's
screen on there.
I think just do presenter mode and then you should be good.
Yeah.
Okay, just give me 1 second. Oh, I'm sharing the wrong screen. Sorry. Let me do this again. There we go. Okay, Queen, apologies. Can you, if you can see it, we can go.
Yeah, that's perfect. Thank you, Maria, and thank you, Rob Murphy and Northwestern for having us this morning or evening from my side of the world. So we'll quickly go through the story behind the creation and scaling up of the NEST 360 technology bundle. NEST essentially standing for Newborn Essential Solutions and Technologies. And as Maria said, we're doing this presentation on behalf of the NEST 360 team. Next slide. Every time you talk about global causes of mortality and morbidity, the first thing that comes to everybody's minds is cardiovascular disease, strokes, ischemic heart disease, and sometimes we also think about lower respiratory infections. Even though these are known to be leading causes of death and disability across the globe, but number one as a leading cause is neonatal conditions, and this covers the whole range from babies that are born early, infections, but also babies that suffer from trauma around about the time of delivery. And so it's important that we pay special attention to these neonatal conditions. And when you look at the global burden of neonatal deaths, it's quite shocking that 1.1 million babies die every year in Africa. When you look at the global burden, we're talking about double this, but half of these are dying in Africa. And shockingly so, even when we've moved so much, getting our mothers stopping delivering at home and coming to deliver in the facilities, yet we still have a high number of babies dying every year. And what really breaks our hearts is the fact that the bulk of these deaths are actually preventable. 80% are actually preventable. Preventable using interventions that we've known over the past 4 or 5 decades. Next slide. Now, what is this, an animal called NEST? Are we talking about a bird nest? As I said, it stands for Newborn Essential Solutions and Technologies. Who are we? So we're essentially an alliance of international experts from across all the continents with one ultimate goal, and that is to end preventable newborn deaths in low resource settings. Remember, 80% are preventable. So we've come together to form this formidable force that works towards this goal. And what we're doing is to deliver a package of technologies and services that enable governments like the Malawi government to improve outcomes, save lives, and empower the medical workforce of the future, but also the present medical workforce. And we have 3 main elements. So we're thinking through innovation, so thinking around technologies that are affordable, effective, and also robust within our settings. So making sure that we deliver such type of technologies, thinking through the educational ecosystem, and Maria will go into the details. And also, it's one thing to do something in the project mode. It's a headache to sustain and actually scale it up within a routine system. And so one big component around this NEST 360 philosophy is learning on how we can scale, how we bring this within routine systems. But ultimately, we want to reduce newborn mortality within the African hospitals by 50%. And so we are working in 4 countries. Currently, we're in Malawi, Tanzania, Kenya, and Nigeria. We call Nigeria the giant of Africa. If you get things done in Nigeria, you should be able to move the indicators and the data within the African region. And within these 4 countries, we're in 65 hospitals. And these 65 hospitals together deliver 500,000 babies every year. And they admit 90,000 plus newborns every year. And these are small and sick newborns. And we're not just doing this in isolation. We're very excited at the global level We're all talking about SDGs, and SDG 3.2 is what excites us, which talks about ending preventable newborn deaths. And all countries, regardless of where you are, we've been given a target of 12 and below as your neonatal mortality rate. And then about a year or so ago, again, through the global community, they've introduced every newborn action plan coverage targets for countries. And they're now talking about 80% of districts having at least one level 2 inpatient unit to care for small and sick newborns. So just for friends that have joined the webinar that have no idea what I'm talking about. So neonatal care, small and sick newborn, we normally break it into 3 levels. Level 1, normal baby, healthy, they cried, I don't need to worry about them, I just need to do a normal clinic follow-up. Level 2, these are babies that are either born small or are sick. They have an infection on board, so they need a little bit more. I need to control their temperature. I need to assist in their feeding. Some of them are struggling to breathe. I need to be able to give them oxygen. There is this level between level 2 and level 3. And this is what we're calling transition care. And within this transition care, it's kind of level 2 plus, where you're now introducing CPAP. The normal oxygen is not enough. So you are introducing CPAP that then helps these babies breathe better. And by the time you're getting to level 3, this is neonatal intensive care, ventilators, and these all really interesting high-level stuff. But the back of the small and sick newborn will require level 2 and level 2 plus. A smaller percentage will require intensive newborn care. And what NEST is really focusing on is level 2 plus. Next slide. And so I can't re-emphasize these 3 main pillars: delivering innovation, developing the education ecosystem. We need to develop an Africa that is able to create these technologies, innovate through our engineering schools, come up with these robust maintenance plans. And that's how we'll be able to sustain the system. But also implementing evidence-based care, really, really critical. And so this alliance, as I said, big alliance, clinicians like myself, engineers, implementation researchers, educators, data scientists, public health experts, and business experts. It's good to have a technology, but you need to get it to a place where it is really needed. And that's where the likes of Karapara Mountain come in, to bring in some sense that, yes, the science is good, but does it make business sense? So we also have business experts on the table, and 16 different partner organizations. And so this covers universities, companies, and NGOs. But 11 out of these 16 are African institutions. And they're all working with and in support of governments in the 4 countries that I mentioned earlier.
Thank you, Queen. For the rest of this talk, we've divided it into each of the pillars that Queen talked about. And I'll discuss in detail 2 of them, and then Queen will come back and discuss the final one. So many of you are very familiar with an image like this, an equipment graveyard. And our goal in NEST is to make sure that equipment that is delivered does not end up in the equipment graveyard. And I will discuss this and the ways we approach this specifically. So newborns, it turns out, need very specific comprehensive care. The NEST team started thinking about the various pathways of care that are required to treat the newborn. And the newborn is quite unique in that it is absolutely necessary that they have clinicians, nurses, doctors, a team of medical experts to care for these babies. But those medical experts, they need to be supported with equipment to be able to provide the kind of care that these babies need. And so we've tried to really, as a NEST team, delineate what are these pathways of care, and further, what are the technology categories within those pathways of care that are necessary? And it turned out that while at the NICU, for example, down the street from Rice University, where I'm sitting right now, they have all of this equipment and more to provide care for the newborn. In places in Africa, they don't always have access to the right kind of technology to provide this care. But what we did is very carefully reviewed these pathways of care and identified which technologies were already commercially available and which needed to be developed for this environment. And so I'm going to talk about how we get the equipment we need and separate it into these two categories, because some are already commercially available. So how do we identify those, source them, and get them to the clinics where they're needed? And then where there are holes in the technology, how do we work to fill that gap? And when I say, how do we work to fill that gap, I don't mean literally how do the people on the NEST team work to fill that gap, but what we want to do is make sure that the entire innovation and invention community and medical device community is able to be mobilized to develop technologies for this space. So in the cases where commercially available devices are available, how do we pick the right ones and how do we get them delivered to the clinic? We started with working with UNICEF, and this was an effort led by Kara Palamountain of Northwestern, with many others working very hard to develop target product profiles, a description and detail about what is required within each of the product categories to have a product that could be used in the neonatal wards in Africa. Kara and her team, including Becca Kirby and others, did an initial landscaping exercise where they looked across all of the available technologies, including technologies in development, and created this amazing compendium called the Newborn Technology Landscape. Not only did they create this and post it publicly, but every 6 months they work to make sure to revise it, review it, add new technologies. And that allows people to go and look for all the different kinds of technologies that might be available, for example, for jaundice management or for thermal management. And they also would have a peek into what is in the pipeline in development. For technologies that meet those initial TPPs, we perform a technical evaluation, including a desk evaluation, looking at what do the different products do, how well do they meet the target product profiles, but just based on reports from the manufacturers. We follow that up with technical testing in the lab. So we bought all of this equipment. We did technical testing in the lab to ensure that indeed they were delivering what they said they would deliver. Or if they didn't have a claim, then we would test that as well. We performed intensive environmental testing and usability testing and created these report cards. And we continue this work as new technologies are available. And in the end, we have something we called a list of NEST qualified technologies. So what does this mean? This means that in the category of phototherapy, for example, we have to this point identified 2 different products from 2 different manufacturers that we feel are rugged, robust, and quite usable in the environment that we're talking about. And over time, we expect this list to grow. Something that's really important, and actually early on in the NEST program, there was a misconception that we were going to identify or pick one winner, and that would be the NEST for phototherapy device, for example. But actually, we want to have more than one product in each product category, because you never know when a manufacturer may stop manufacturing. We think competition is good. If one product was the only one selected, maybe they would start thinking they should raise their prices. And so we actually want to have a wide variety of products. It's better for the community to have more options of tools that they can use to provide this newborn care. Once we know what technologies are qualified, we have worked together as a team and basically created Hatch Technologies, which is a nonprofit global distributor that can work as the liaison between a local distributor in a country and the global manufacturers. And so Hatch is working with local manufacturer or local distributors in each of our countries in order to be able to deliver and sell Nest qualified technologies in each of these countries. And as I mentioned, they work with local medical device manufacturers to be able to sell and install, and most importantly, track and help maintain through warranty service the technologies that are purchased and installed in Nest facilities. So there's this other category that I mentioned where a technology might not yet exist, but the need exists. So I'm just going to show you some exciting new products and new developments. I'm only showing two that have been developed as part of this Nest work, but there are others that we are equally excited about. I just don't have quite as much of a view under the hood for these technologies. So one of the technologies was a point of care bilirubinometer. Laboratory-based bilirubinometry sometimes has been difficult to obtain. Doctors who want a serum bilirubin test on babies want to know the answer immediately because they often want to be able to do several at once, and sending something off to a lab that may take days to return doesn't work very well. So we developed BiliDx. It has been clinically evaluated in over 600 neonates in 3 hospitals in Malawi and in Nigeria. And we have been able, without getting into many of the details, we've been able to demonstrate that the BiliDx system has, in 93% of the time, would give you the same treatment decision as the laboratory reference standard, whereas the transcutaneous system was not able to perform quite that well. And very excitingly, this product is just right at the tail end of receiving a CE mark and will be available early next year. And in the process, we learned, those of you who might be interested in developing products, we learned some lessons, and so I'll share those with you. One is that engaging the manufacturers early in the process is really quite important. We missed an opportunity to reduce the consumable cost, and we will do that in a subsequent revision, but it was going to slow our timeline too much to sort of reconfigure for this version 1. And so we keep pushing ourselves to include the manufacturers earlier in the process. We have also developed a temperature monitor, a continuous temperature monitor called Celsi, and you can see it here. And some of the measuring temperature is not something that's super exciting, except that what we identified in our work is that hypothermia is a huge challenge, and it is really difficult for the nurses in an overcrowded ward to measure a baby's temperature often enough to keep these babies from going into hypothermia. And it was very important. One of the things that we learned was that it was critically important not to have consumables. So there are no stickers, there's everything that is part of the system can be disinfected and reused so that we don't have a piece of technology that can't be used because the consumable is not available. This graph just shows that it does a very good job of monitoring a baby's temperature. And this product in particular, the design of it was driven by the users giving us feedback all along the way. Next, I'm going to turn to the education ecosystem part of this work. So when you think about providing clinical care, you might think really importantly that you need to train clinicians, which is very true. But we also have some very targeted training programs for the biomedical technicians and biomedical engineers to make sure that this equipment can be maintained and that new devices can be invented locally based on local need. So our team has developed quite a lot of training materials not so much in how to provide, what clinical care to provide, because each of the countries where we're working have very robust guidelines about what care to provide the babies in their countries. Where the gaps that we identified were that how to use the technology in order to provide that care was quite a gap. And so while, for example, the clinicians absolutely knew that CPAP could help newborn babies in respiratory distress, they might not have had enough hands-on experience with particular CPAP devices to know how to use that device to deliver care. So we've created both technical and clinical modules focused on the technicians and the clinicians and job aids that really help the delivery of care with the technology. And something I'd like to point out is that each of these guidelines also includes a section on infection prevention associated with that particular device. And this started before COVID, and we had this in there before COVID, but it's become even more clear that making sure that we don't introduce more danger to these babies because we're introducing the technology. The other innovation with the education that has happened with NEST is that in many cases, we educate the clinicians and the technicians together. And what that has done is that our clinicians have a much better understanding of how to take care of the equipment and make sure that they don't do something like dunk an entire battery operated device into bleach and leave it there for a while and then take it out, because that will damage the batteries, for example. But also the technicians have come away from this training with a much better understanding of why it's important not to leave the oxygen concentrator sitting broken in the corner, why those babies need that device. The other area where we have worked very closely with Northwestern on is invention education. So when we think about the invention ecosystem, we want to make sure that when we're working in countries, we're also working with the engineering schools and their faculty to think about how to bring these real-world challenges to their students and encourage them to invent solutions locally. So we've worked and established design studios at many of our local universities, and these students are exposed to developing technologies as solutions for local problems. During COVID, we saw the benefit of this when our design studios were able to very rapidly fill a gap in access to PPE in our countries. In 2 of our countries, the design studios created hand washing stations, face shields, UVGI disinfection systems, and were able to locally manufacture and install these systems. And very interestingly, it brought acknowledgement from their local governments, and everyone felt so proud to be able to fill a need that frankly these countries couldn't purchase face shields. We had UN agencies purchasing PPEs from our design studios in order to provide for local countries. So this was sort of proof that our idea was going to work. Over to you, Queen. Queen?
Oh, sorry, I was busy talking to myself, not realizing muted. Apologies. So this has been the NEST facility journey so far. So before we go into a facility, remember we have at least 60 hospitals that we're working in at the moment. We have steps that we follow. In the first place, we need to be sure that the facility is ready for us to institute level 2 care, level 2+ care. So there is what we call a readiness checklist we send to the facility, and then we go in person to do a baseline facility assessment. This is the checklist that we're using. It can be adapted for different countries. And once a facility passes this baseline facility assessment, we then go to the installation of the bundle. So within this facility assessment, there are space issues. We want to have dedicated nurses and clinicians, but also maintenance people, biomedical technicians available to look after these pieces of equipment. Otherwise, you end up with another equipment graveyard. And we as part and parcel of the installation, we do these joint user training. So engineers, nurses, clinicians, data people, they all sit under one roof, because we realize each one of us has a role to play. We need to understand the importance of the other cadre in as far as looking after a small and sick newborn is concerned. And then we have these weekly event logs. So once we've installed, we've trained people on a weekly basis, we track. Is there a piece of equipment that has broken down? Did you have power outages? Are there issues that we need to sort out? And so this is all done electronically, but also using a simple phone call. Tied to all these, we have these quarterly QI visits, and these are big. So these are led by the Minister of Health. So we have all cadres joining forces, going into a facility and looking at our performance on all the aspects. And then at the end of the day, we will do what we're calling an endline facility assessment. So we start with a baseline, we know where we're starting from, and ultimately we want each facility to reduce the newborn deaths by 50%. So these are the steps that we're following. We're not waiting by the end of 2023. No, we are doing it on a weekly basis. And a lot of lessons that we've learned. And we've taken all those lessons and developed what we're calling the implementation toolkit. It has several pillars, was launched on World Prematurity Day. So if you want to know, in as far as infrastructure is concerned, you just click on the infrastructure bit. It will tell you, show you floor plans that you can adapt at whichever country you're working in, whichever level facility. You want to think about data systems. Don't reinvent the wheel. Don't sweat. Don't have high blood pressure. Just go on this website, click, and you will be able to see that which will be required for you to move the agenda forward. So loads of documents, is a living website. So things keep on being added to the website. It's not just restricted to the 4 nest countries. We're learning from all over the globe. And it's stories like these that actually keep us going every day. These twins were born early, struggling to breathe, and this facility had just passed the facility readiness. And we had brought in the kit, but was still in the boxes. His babies popped out. Even before the installation training, we picked our Pumani CPAP machines, hooked these babies on the machines, and voila, they're still alive and thriving. It's stories like these that bring a smile on our faces. Next slide. And so having technologies is one big piece. Having engineers, people innovating, having excellent data systems. You see, all these things are good. But medical devices on their own cannot save lives. The same thing, we have COVID vaccines. We still have thousands and thousands of people that are refusing to be vaccinated. They end up in ETUs. So vaccines on their own don't save lives, but vaccinations, devices alone don't save lives. But delivering effective care in this systematic approach saves lives. We need to move from one device at a time, one training at a time, one hospital at a time, one discipline at a time, because these babies are not waiting for us. The time to do it in a holistic manner is now. Thank you very much.
Thank you all very much. We would be delighted to answer whatever questions you might have if you have a few moments.
Yeah, no, that is fantastic. Thank you so much. Just remarkable to see how this program has really evolved over the years. And maybe I'll start off. There was one question, but Queen Dubé just beautifully answered it. They were talking about the sustainability and whatever, but I know that's always been a big part of NEST. So, I mean, it looks like things are really going great. What are the plans for expansion outside of your test countries? Because that is a question that, I mean, I'm only peripherally involved now, but it's a question that I get whenever they hear about NEST.
So I can start, and I'm sure Queen has some ideas as well. So we are in 4 countries. In Malawi, with Queen's leadership and the fact that we've been working there longer than in the other countries, we have NEST at a huge majority of the district hospitals. So we really are at scale. But in the other countries, for example, I'll just give the example of Nigeria. You all are quite aware of the vast scale of Nigeria. It's much bigger. So for example, in Malawi, we are in 36, maybe a couple more. We're in 36 district hospitals, and that covers much of the country. In Nigeria right now, we are in 7 facilities. So we really have seeded, but the next action, of course, is how do we scale up in country with Nigeria, and of course, in a sustainable way. So that the same is true essentially for Tanzania and Kenya. And we are committed to working with these countries to do that. But the other piece in terms of sustainability is that the NEST team, we're using this amazing opportunity that we have to really learn lessons. And one of the things we're doing now, and I'm sure kind of the rest of this phase of NEST and maybe in the next phase as well, it's really thinking about how do we package up the things we've learned and then partner and respond to others who would like to do the same thing in their countries. What the NEST team, sort of the global team, does not envision that we would start going to every other country in sub-Saharan Africa. What we want to do is build on all the expertise of others in those countries doing work like this and figure out what are the things that the NEST team can do to help facilitate, what are the learnings that we can share. And we're really struggling, or not, I won't say struggling, but really thinking right now about how to do that effectively. Because it's not, it isn't a reasonable thing to think we would do the same kind of engagement in every country that we're doing where we are, but there are others that are as deeply engaged in other countries that really should, we hope, would learn from the work we've done and that we can come alongside and work together and share. Pretty much everything we've developed in terms of what we're thinking of as global public goods are freely available to anyone to use. The education materials are in a format that if countries would like to take them and adapt them, they're published under a Creative Commons license, so they'd have to refer to where it started, but they're able to make modifications as appropriate for their own countries.
No, great. It's a fantastic program. We've got a couple questions here. Can Dr. Maria and Dr. Queen discuss their career path, read global medicine and newborns? This is from Judith Bazel.
Queen, do you want to start with that?
Thank you very much for that question. When did it start? Well, I think when I came back from my general peds training and saw the differences between what we're able to do in Europe vis-a-vis what we were struggling with within the sub-Saharan region. That really made me start to think that there must be life beyond just this hospital that I'm working in, and started to explore. At that time, I didn't even know that it was global health. It was a quest looking for people that could hear our cry on what needed to be done to improve survival for our newborns in Malawi. So went to WHO, went to Save the Children, went to UNICEF, and all this jargon around global health, I didn't know. And so it was through this drive wanting to get assistance that I was introduced into global health. And I don't regret, not even once. And sometimes when you're so passionate as a clinician, you think when you're dealing with those 10 very sick babies, you're doing great. But that's less than 1%. Because we live in a global village and there's a lot that determines what happens in that facility X where you are working. And so I realized that, I needed to change to allow myself to explore on this path of global health. It wasn't intentional, to be honest with you. It was out of desperation. And then I discovered myself as I spoke with these global entities, and I haven't regretted. And I think Malawi, we've benefited with all these links that we've had with our global partners, but also our contribution on the global level has just been amazing. Just to touch a little bit on what Maria also talked about shortly. Earlier this week, we had a WHO meeting for the African region. And on the agenda was small and sick newborn. So we are taking advantage of platforms like those to talk about what is available through the NEST platform. We're saying, we've done the donkey work for you. You don't have to worry about it. You can tweak things here and there, but don't start with zero prototype. You can start from maybe the beta or the what have you. And that's what we are doing. We cannot do it the way we're doing it in Malawi, but we can share, we can provide the support, and we can hold them by the hand. So let me stop there. Over to you, Maria.
Sure, I'll be very quick. So I would say I had two pathways to this work. One was professional, in that I was teaching bioengineering capstone design, and I find that students who are passionate about the project they're working on actually learn more and work harder and are more successful. So I was on a hunt for projects that early on would be interesting to my students. And I care a lot about sort of giving students, not only mine at Rice University, but all around the world, this opportunity to solve real world challenges, because I think when they see what they can do, it's very, very powerful. On a personal side, I was born and grew up in Brazil and had maybe a different view of the world than some of my colleagues that have only ever lived in one country. And on top of that, 3 of my 4 children were either premature or one of them was quite sick when she was born. She wasn't premature. And so personally, I have seen what having access to the kind of care that my children had access to in Boston and in Houston, how that can be transformative. And when I first visited Malawi and saw that babies that really just needed a couple of days of CPAP and being held warm were struggling to survive, it made me realize the huge gap that we had, and I wanted to do something to fill that gap.
Thank you both very much. This is a very medical and biomedical engineering audience today, so thank you very much for your insights. One last question, and then we're going to move on. So Lisa Hirschhorn says, does NEST look for technology for safe transport from home or lower level deliveries of these sick young infants?
It's an area that we have not yet gone diving into. We are right now thinking about what are additional technology areas that we should be thinking of, for example, to do landscaping, to create TPPs. And this is an area that is on our radar. We just have not done work in that area other than sort of anecdotally, but I think it would really start with doing some landscaping, creating some TPPs, and trying to get the word out there that this is a great need. And I think there are some amazing innovations out already for this purpose. And so I'm not sure necessarily that there's sort of new innovations needed, but perhaps elevating them sort of in our process would be beneficial. So really, thank you so much for that plug for the transport technologies.
Great. All
And I
right.
just want to thank Rob, you personally, the Northwestern team, for all of your contributions to NEST. Much of what I talked about wouldn't have happened without you, Dr. Glucksberg, Kara, and the Northwestern team. So those of you watching this talk, if you think it's really cool, and it's only really cool because of the impact of your faculty there as well.
Well, thank you very much. Really appreciate that. And thank you both, Queen Dubé and Maria Odin, for this wonderful presentation and report on this incredible project. Thank you so much. All right, now we're going on to our second plenary, and it's a great pleasure to introduce Dr. Louis Pizero. He's team lead with Untitled, which works with partner organizations to leverage innovation for global health. And he's particularly engaged in HIV treatment, long-acting treatments, reproductive health, and equitable access. He previously worked at and directed Soltis, an NGO, French NGO, which works on health system strengthening in Africa, primarily in Francophone Africa. He was the first head of the Niger mission there, and he also supported the government there in establishing the National Program for Access to HIV/AIDS Treatment. Today, Louis joins us for a discussion on the equitable access for innovation in the global health space. Louis, take it away. You have the floor. We thank you very much for participating today, live from Geneva, Switzerland, by the way.
Exactly. Thank you very much, Robert. And good morning, good evening here in Geneva, everyone. Thank you very much for the invitation. As you said, Robert, I'm working today at Untitled, and I would like to develop a little bit on innovation and then showing you what we're doing here at Untitled. Before I start, I would like to confirm what you heard before NEST. It's really a solid organization. I know here at Untitled have been looking at this work in order to inform our work on our investment or MNCH, and I know my colleagues appreciate very much the work they are doing. So congrats for that, guys. So let's go for my presentation. Let me put that into here, and starting by telling you what is a little bit Untitled. I want to just to introduce that because we are in a university academic here setting, and I think it's good to have in mind what happened in the early 2000s when this MDG agenda was put in place. We had two big phenomena. We have first an incredible, raise in the development aid for health that was absolutely outstanding. Never have seen that in the past. And second, we had a lot of new actors coming. We call them the Global Health Initiative or Global Health Partnerships, and Untitled is one of them, created in 2006. I think it's good to have this sort of typology of global health actors, between here in the core, the public actors, governments, multilateral system, the private one in the peripheral, like NEST, you have seen, academia, NGOs, or foundations, and the global health initiatives are between the public and the private. Some people talk also about public-private partnerships. You can have different elements, but those are really very new. And you have, let's say, three types of global health initiative. You have those who are financing mechanism, and Untitled is one of them, like Havey, Global Fund, very well, and a new one coming, GFF. You have others that were created more to coordinate actors like Rollback Malaria, Stop TB. And you have very interesting one too. We call them the product development partnerships. You have DNDi working on neglected tropical diseases. You have Fine working on diagnostic, for instance. Those are very specific in the research and development side. So once we have that in mind, Unitaid, as I said, is a global health initiative founded in 2006. France and Brazil were key to put that in place, but also countries like Chile, Norway, and the United Kingdom. And the idea here was to say that a lot of investment was brought to buy drugs, let's say, to buy products for the 3 diseases that were leading the agenda at this time, HIV, malaria, and TB. But we needed in the middle something to promote innovation, and that was the reason why Unitaid was created. Good to have in mind that it's not only a private-public partnership because funds come from the public and the private sector, but it's also a PPP because the governance of those organizations are hybrid. So you see here, for instance, the executive board of Unitaid. You see some countries, but you see also that foundations, NGOs, communities are part of the board, and they take a strong part in the governance and the decisions that are taken. It's good also to have in mind that behind those global health initiatives, people were looking for innovative funding mechanism. Of course, we're going to talk now on how we promote innovation, but the innovative way to raise funds was also in the core of the foundation here. And clearly, for instance, for Unitaid, the French decided to put in place an air ticket levy that was taken every time people were buying a plane ticket, and also they put it in place a financial transaction tax, to put in place this solidarity fund and invest in innovation. So good to have that in mind, innovative way of funding. I think before I show what is Unitaid, when I was asked to talk about innovation, I wanted to remind, because sometimes we do confusion between innovation and research. And I think it's good, this definition from 3M Vice President, you see here, when we talk about research first, is we invest money to respond to a question and produce knowledge. And innovation is when we use this knowledge to produce value. Could be, of course, money, but it could be also human value, social value. And I think for the students, etc., it's good not to make the confusion between both. And when we talk about innovation in health, we have seen just before some innovation Nest is producing, but there is, let's say, hundreds of different ways to produce innovation. And it's not only about tools, about therapeutic, it could be, of course, about technology, but it could be also about organization, policy. So innovation, let's say, it's everywhere in the health sector. And people is starting to try to assess the impact of this innovation. And for instance, this is a figure that it's used by the Global Fund to show how the international community should invest in innovation and how we save lives doing this. And here we can reduce, the target of 3 years if we want to reach the objectives we have for the 3 diseases. So very, very important. And just because we're also in an academic place here, I thought it was interesting for you to think a little bit, because innovation now is used in very different manners, how we have moved from a word called progress, we that are older than you were using in the past, to innovation today. And what it's a little bit a pity is that when we were talking about progress in the past, we were thinking on the world we wanted to build, and we were trying to develop things to go to this objective. Unfortunately, today, innovation is much more used to try to fix the problem we have And we're missing a little bit this prospective vision we would like to have. So for you students, if you engage here, it would be good you try to think about the world you want to build and then think about the innovation and not just thinking on how we fix the problems we have now. And the second aspect, because it was about access to innovation, it's good to see that there are a lot of, let's say, barriers we need to address when we talk about access. They can come from the supply side, and most of the time people just look at the supply side, but it's also good if you go and you try to invest in field projects, etc., to see what is happening at the demand side. Because if you don't address what are the bottlenecks in demand side, you can have the better tools, you will not do that. And I think it was also addressed during the presentation of Nest. It was very, very good. And access, it's key, but people is also looking for quality. So bringing, products, if you're not thinking on the quality of the service, will not be enough. And this is what we try to have in mind at Unitate when we think about this. So what is Unitate? Very simple. Our aim, let's say, is really to try to maximize the effectiveness of the global health response by catalyzing equitable access to better health product. So it is about innovation, it is about access, but you will see it is also about scalability, because we invest, let's say, in pilot projects, and the idea then is that we can scale up this innovation further. And if there is only one slide I will ask you to keep in mind is this one. We think at Unitate that the gap when we were created was here in the middle. A lot of people were doing, here in the upstream, producing this innovation, doing research, of course, then thinking about how to transform this knowledge into value. So you will have academia, startups, those product development partnerships I talked before, industries, foundation, other, etc. They bring new tools, new drugs, new diagnostics, etc. We have here in the downstream governments, Global Fund, PEPFAR, and a lot of donors that are ready to scale up those innovation and trying to spread all around. But if we miss the value chain we have here in the middle, we miss everything. And what does it mean? And it's very, I think, let's say we can compare with what Ness was saying before. It's of course about scanning where this innovation is produced and having this global vision. And that's why I said, for instance, in RMNCH, we were looking what Ness was doing. It's thinking about, is it available, this innovation, or it's just, at a very early stage? Once we have target the products we think they are useful, do we have the good quality? Are they pre-qualified? Europe, FDA, by WHO and others? This is absolutely key. Third, are those products affordable? And if not, can we intervene to shape the market in order to reduce prices? And I will come back a little bit later on that. After that, is the supply and delivery chain in place, or do we need to invest also on this supply chain? And finally, and this is really very, very important, you can have an amazing innovation, good quality, low prices, you have enough to supply to the countries. If those who are supposed to use it, health workers, patients, communities, they don't have really a demand or they don't know how to use it, it will never work. So it's really a comprehensive work on this value chain that will allow the innovation to be completely scaled up at the downstream level. So please, this is really what summarizes what we do. So you see, for each step of the value chain, you have different tools we can use to put that in place. As I said before, for instance, for affordability, we can negotiate price, we can co-pay, we can work on intellectual property to make those products more available, etc., etc. I will share, of course, this presentation with you. And if you take some examples here, we have been looking, for instance, on innovation, how to invest in pediatric antiretrovirals, because that was completely neglected by the international community. We have been working, for instance, on how to register in different countries rectal artesunate for malaria. We have been, as I said before, negotiating prices. We work with the Child Foundation for this, you know, to really slow down the price, for instance, of dolutegravir-based regimen, etc., etc. So at different level of the value chain, very important actions. And the way we measure our impacts, it's here. We intervene at the beginning. Okay, so we are just in 1, 2, 3 years. We're going to look, you know, to of course succeed our grants, to try to overcome those critical access barriers I talked before, and then discussing with the donors to secure fund for countries and being sure we are leveraging this intervention. And if I take, for instance, an example here with seasonal malaria, you see in yellow the investment of Unitaid. We were those investing the more at the beginning. We brought partners into the field to invest here. And then when we stopped investing, the investment from other partners continued to increase. So we not only, you know, produce this catalytic action to bring all the partners with us, but we were also, of course, leveraging the impact we had on chemo prevention. So this is, I think, a very, very good example. How we function for this. First of all, we look, of course, as I said before, access, availability, potential public health impact. We're not going to invest everywhere, so we need to look where the impact can be bigger, and when also there is a critical gap to the response, because we're not alone, a lot of people is working here. So when we target that, we're going to develop disease narratives. I really encourage you to look in our website. Those are documents not done by me, so I feel very comfortable to say that, but by our strategy team that are really comprehensive, and more of my students, I ask them to read it. They're really very well done. And once we have this disease narrative, we're going to let's say, scope in specific areas of intervention to then go for call for proposals. So you can find everything here in our website. And those are the areas of intervention we have now. You see, as I said before, the maternal and newborn health, it's a new one. But most of them, of course, are around HIV, TB, and malaria. Good to know, we're investing also a lot in COVID, therapeutic and diagnostic. I took just maybe one example, is our HIV portfolio. So we're going to see, you know, the different steps, of course, about test, preventing, treating, and monitor. And today we have grants on self-testing for HIV, early infant diagnosis at this level. We have a very, very big grant on antiretroviral optimization with the Child Foundation coordinating. We have invested in the past in viral load, but also in the prevention. We're working with South Africa and Brazil on PrEP. It's absolutely key, of course. I will let you know a little bit what we do in intellectual property. It is what we call a cross-cutting intervention. But we don't forget that there are co-infections here. There are co-infections, you know, when we have advanced HIV disease, like cryptococcus meningitis, for instance, but we have also some other, not co-infection, but co-morbidities like cervical cancer. The example of self-testing is one I've been following when I was at Soltis before, because we implemented this for West and Central Africa, but also now from Unitaid. And it was really very interesting to see that in West and Central Africa, where the coverage of HIV is really very weak, one of the issues was that people that were working like sexual workers, men having sex with men, or some other populations that were what we call vulnerable population, didn't have enough confidence, let's say, to go to the normal testing services. We thought that it would be very, very interesting to try to develop this. So we first engaged with OraSure that was doing oral test in the US to see if these tests will be qualitative. Second, to see with them how we could let's say, slow down the price, as I said before, trying to really push for a strong reduction in the price, how they could produce enough to scale this self-test all around the world. And then what was very, very tricky was to think about how those tests could be delivered in the field, how we could engage with NGOs, local NGOs, communities to do that, how we could assess the result and the link from the test to care of those patients, because it was absolutely not evident. And during 4 years with PSI in South Africa and with SOLTIS in West Africa, we have developed very, very important guidance that have been also discussed, of course, with WHO in order to have now a worldwide guideline on self-test. And PEPFAR and Global Fund are funding now in most of the countries they intervene actions on self-test. So this is, I think, a very, very good example of that. And you see here that we reduced the price to $2 per test. We did a little bit the same for pediatrics TB formulation. You see here the issue for children to take those doses with a very, very bitter taste, you know, impact on adherence, etc. And we are also succeeding now to bring for those children drugs that are really adapted to them. So I don't want to be too long, but also let you know, and I think it's very good, I go just after the NEST project, that we are investing in cervical cancer, but also in fever management with children. We have 2 strong projects on pulse oximeter, and we're going to invest further on antimicrobial resistance just to, let's say, improve management of fever for children in very decentralized setting, because it's key to know if the families are going to bring the children to the central hospital, or if it's possible to take care of them near their houses. So very, very strong. I would like to finish maybe saying a few words, first of all, on the role we have on ACT-A. You know, ACT-A is the architecture, the international community put it in place to develop innovation for COVID. So you have heard probably on vaccine, because we have COVAX who is doing a lot, but we have also 2 other pillars. The therapeutic one, where we'll welcome Trust leading this, and of course, trying to, you know, not only at the beginning work on monoclonal antibodies, but now with molnupiravir and Pfizer drug, trying to see how we're going to develop that if it's possible. And we have been with FINE and the Global Fund investing on a new diagnostic tool, the antigen one for sure, but also thinking on sequencing, you know, tools. And both together, we have launched last month 7 grants for $50 million on test and treat strategy for COVID. So I think a very important piece. Last point, I said innovation, I said access, but we were talking about equitable access. And equitable means that you need to adjust the response depending, of course, on the needs. And that's why we created 10 years ago an organization called Medicine Patent Pool that really started at Unitate. And the idea here was to say, okay, there is a legal frame today we call the TRIPS agreement. It's on intellectual property. And there are some rules countries can use in order, to adapt, let's say, intellectual property and push for access for choice. But there is also another possibility, that is to engage with pharma companies and saying you can keep, your one-on-one market agreements with high-income countries, so maybe middle-income countries, but for low-income countries that are not a real market for you, why don't engage with medicine patent pool, go for what we call a voluntary licensing, and then the medicine patent pool will engage with generic companies in India, of course, but we see now in Africa, in Brazil, and in a lot of continents, a lot of new generic companies coming and being ready to take with this voluntary license, the production of those products, and of course, sell it to those low-income countries in a very, very low price. And if we do that with a lot of companies, we also push for competition. And when you have competition, you reduce prices too. So that has been absolutely key. And in the COVID situation, is the medicine patent pool who has been negotiating those licenses with Merck and with Pfizer for the two products you see here. And this is going to be a real game changer to try to make those two drugs accessible very quick for low-income countries. Okay, so very important. And just finishing saying that, of course, if you want to work here, it's not a Geneva organization, that comes with the solution, etc. It's absolutely key, the engagement we have with different partners, civil society, research, guys like you, and the discussion we have. So we know the value of engaging with those partners. And we have today 63 projects, as I show here, on HIV, fever management, hepatitis, TB, and malaria. And our global portfolio, it's about $1.3 billion with the share you see here. So those are most of the partners we work with. Very proud, you see, from NGOs, academia, in the north, but also in the south. So a very, very big ecosystem. That's it for the moment, and thank you for your attention.
Thank you very much, Louis. That was really incredible. There's please, if you have a question for Dr. Pizero, please put it in the chat box. I've got a couple questions. There's a lot of the people in the audience, the students and some trainees and stuff. A lot of them have some desire to work globally in some kind of organization like, at WHO or, some global NGO like Soltis or some equivalent to Soltis in the Anglophone countries. But can you give us a little career pathway description, how you went from a medical doctor to being a team lead at Unitaid, born in Chile and living in France and now in Geneva? Like, how'd that happen? I know, but I'm not gonna, I'm sure they want to hear it from you.
Yeah, well, like my colleague before, first of all, I'm very lucky because I'm half Chilean, half French. So I was born in Chile. I lived there for my first 20 years, and having this, let's say, international background from the beginning, for sure, I think it's good. So, I mean, some of you that maybe have different origins, etc. Not only you need to feel proud of that, but you will see it's absolutely key, I think, to open the vision and having this global vision. Second, when my students asked, about this, I said, don't be scared before 30 years old to explore very different, opportunities, experience. Of course, we talk about going to the field, like a first initial experience you need to have, but guys, the field is just around the corner. I mean, we have here in Geneva, in France, and probably you in the US, so many things to do if you want to have a grant management experience, you know, around your place that you can start by that. You can, of course, if you have the possibility, go to work in Latin America, Asia, Africa, and that would be great. But I would say more than that is your appetite to really engage in something concrete and trying to explore different paths. The second advice I give is to try to think if you are going for a management position, you know, grant management, people management position, and you want to then develop this competency, or if you are more interested to become an expert, you know, with a very strong technological, technical, scientific expertise, because the path you're going to take will not be the same. In the first one, you don't need to do a PhD. You really need to engage yourself in very concrete experiences. In the second one, I'm not saying that it's compulsory to have a PhD, but for sure, you will need to you develop a strong expertise because the competition is hard. For instance, for a position here in Geneva at Unitaid, we are based and we're hosted by WHO. Every time we have a position, we have around 300 to 400, you know, application every time. And most of my colleagues, they have a PhD and things like this. So it's not really the same, I would say, approach. And maybe the last one is to, I would say, is really to, yeah, to follow your sort of good balance between your heart and your mind. I mean, if you don't have an engagement, personal engagement, you will not succeed. But personal engagement is not enough. And trying to bring, you know, a sort of rational perspective to that and finding the good balance between both, it's absolutely key.
So do you think, I mean, just to follow up on that, are most of the people in positions like yourself, they also, if they're medical doctors, do they also have a PhD, or are there other degrees that?
No, I think when you are a medical doctor and you are having, let's say, a management position like I have, it's absolutely enough. You don't need to have a PhD. If you're a medical doctor, but you want to join our strategy team and being, you know, the head of the HIV department, for instance, for sure, most of the application will have a PhD. So that's why I'm saying it depends really, you know, on the orientation you want to give.
All right. Hey, we have a question here from Jaylene Girardin, who's in the Institute here. She's a malaria and coronavirus modeler. Runs a big unit with us. She says, how does Unitaid approach more cross-cutting domains such as health system strengthening as opposed to individual diseases or technology types?
Yeah, of course, it's a key question. Well, let's say first that I think Unitaid, as I said before, was funded in 2006 when the international agenda was the MDG one. So everyone was very disease oriented at the time. We recognize now that we have the SDG agenda, that it's much more, as you put here, multi-sectoral, cross-cutting. And it's not only around health, it's also how health with education, with environment, the One Health agenda, people is interacting with that. So we are producing our new strategy. But for organizations like us, what is critical is also to be very clear, you know, where is your place in the whole global health architecture? Because as I said before, we are not alone. So clearly, we see that there is this niche, you know, I call the value chain, you know, World Bank, even now the Global Fund are investing a huge amount of funds and energy on health system strengthening, and they have the, I would say, the added value for that, it will not be our case. But the way we look at this is what I put it in one of the graphs, cross-cutting approaches. So for instance, the intellectual property one is a cross-cutting, because when we succeed to have an impact on this intellectual property, it's going to be applied for all of them. And the second one, as I tried to illustrate with the self-testing grant, is how we really engage in a very early stage with you know, the local stakeholders, those who have the need first, who have identified you know, what could be the solution, and how we test with them you know, not only this need, but what could be the way to implement this solution. So it's really about implementation science, in fact. And I think that's absolutely critical, you know, to have this health system impact at the end. So again, it's keeping our niche, looking for those cross-cutting perspective, and being sure that the patients, you know, the communities are at the beginning of the solution.
Louis, Jaylene, thanks you for your answer. Very nice and thorough answer. Back to the last question that I asked about the other degrees and stuff. So Judith Maisel says, well, what about a Kellogg MBA? So you know, I'm sure you've heard of the Kellogg School. It's probably the most famous school at Northwestern. They have a huge global program. So that's one thing, but also, yeah, your own other degree you didn't mention. Yeah.
When I was finishing my medical studies and I realized that I wanted to work on global health. The time we call that international health, in fact. But I did a master in political science, international relationship at the Sciences Po Institute in Paris. And of course, that was absolutely, I would say, key to understand. When I went for the first time to Niger, you know, we came like, let's say, MSF style, saying, okay, we're going to work with you on HIV, but we're going to buy the drugs, buy the devices, and treat patients. And I realized that, no, the Ministry of Health was saying, guys, we have received a lot of money from the Global Fund, the World Bank, and we don't need you to do that. We need you support our national program in order to be autonomous and to have a sustainable approach here. And hopefully, I think the fact that I studied that in the Political Science Institute was good to very quick understand this and switch the strategy of the organization. So if you are thinking about something on international relationship, I think it's good. And then when I took the direction of Soltis, we started very small, but hopefully we were growing. And of course, my medical studies were not enough to understand HR, to understand how to present my budget to the executive board and how, you know, to deal with a business plan, for instance. So I did an MBA also, but the MBA, normally you do it when you have, I would say, more professional experience. I'm not sure that doing the MBA just after your medical studies will be so necessary. So as I said before, take your, I don't know, 5, 6 first years to explore, to do a lot of different things, to test what is really your passion, where are you going to really invest your life, in fact. And once you know that, and you decide that this is the way I want to talk, yes, adding those trainings could be very important.
Thank you, Louis. We have a lot of interest in global work in the Kellogg School, and I think they're doing kind of like exactly what you just said. We have a few more minutes if there's any other questions. I have one relevant to the prior presentation on the NEST program. What NEST was basically part of the MacArthur Foundation, big giant grant challenge where they gave, $100 million. And this was kind of There's 4 finalists. Nest was one of the 4 finalists. They did not get the first prize, but they got the other foundations that work with MacArthur to actually fund it. So they ended up with like 2 winners that year. Now that they've got the basic like program down as was described, and worked through many of the challenges and have been really quite successful, as Maria and Queen discussed. What kind of international, where does it go from there? Where do these partner institutions and stuff that you work with, I mean, say it works in 4 African countries, how do you get it out in a broader case? Because I've made this presentation before and people are coming up to me from Colombia, and you know, and Vietnam, you know, I mean, all around the world, you know, there's a lot of need for this, particularly in the lower income countries.
Absolutely.
There's some way you could tie it in with that.
Yeah. When I showed, you know, what we call the cassette, you know, upstream, downstream, we're in the middle. I said that at the downstream level, this scaling up, you know, action you're looking for, it's done by the Global Fund, PEPFAR, mostly Global Fund and PEPFAR. That works when we talk about HIV, TB, and malaria.
Right.
And what is tricky is when we go outside of the 3 diseases or the co-infections that go around. So we have tried, as I said before, for instance, for cervical cancer, we have made the link. But when we started investing in RMNCH, reproductive, maternal, neonatal, and child health, that was something we were, you know, hesitating, because we knew that there are a lot of things coming, and Nest is a very good example, but there is still not enough scaling up actors, donors that are investing as Global Fund is investing in the 3 diseases. So because the needs are so strong, we said, okay, but let's go and let's try to put in place a dynamic for this. I said before, there are some initiatives like GFF, the Global Financial Facility that is hosted by the World Bank, who is trying to invest in maternal and child health, of course, engaging with UNICEF and others, but there is still a lot of work to do on this place, and we are not already done for sure. But my second part in the response would be, it's also good we try to make the difference between low-income countries that are absolutely dependent on foreign aid versus middle-income countries where there is capacity, you know, to mobilize domestic funds. You were mentioning Colombia and others. I mean, here it's more about, you know, I would say political engagement and how we advocate with those governments in order to prioritize national funds, domestic funds in this type of issue. And that's why at Unitate, we know that our main work is to be, you know, a financial mechanism, but we try also to, let's say, to strengthen a little bit our capacity, you know, to convene different actors and to advocate with national governments in order to produce this scaling up approach you were mentioning.
Yeah. All right. Any other questions for Dr. Pizero? Wonderful presentation, Louis. Refreshing to hear your perspective about Unitate's role in scaling innovations. Good comment for you. Okay,
and I really, just to finish, because I'm talking to a public that will be interested in that, say, guys, have a look on the website, subscribe to the newsletter, because every call for proposal we do, it's of course published there, and we encourage, you know, we want to, let's say, enlarge our portfolio of stakeholders working with us. We don't want to keep always the same. So very looking forward to receive proposals from you. And we have developed also a sort of startup mechanism we call Unitate Explore, where we are trying to to bring space for smaller organizations that have, let's say, $1 million projects. Most of our grants are around between, let's say, $5 to $20 million. So there are strong and big grants. But we know that with academia, we have on neonatal health, we have something about, pneumonia with institutions like the Polytechnic School here at Lausanne and others. And we do this in this United Explore facility. So I encourage you to have a look on the website and let us know if you want to apply. I'll be more than happy to engage with you.
Well, thank you, Louis. Oh, and I want to give you an update. The last time we were physically together was in Lyon. Remember at the conference on kind of innovation technologies, and I presented the DASH project. I know you may remember the 15-minute PCR. So thanks to a really nice NIH grant to continue the development and a larger grant to scale up. Actually, Sally McFall and Matt Glucksberg, who are on this call, and Chad Achenbach have actually moved that forward, and they've submitted the EUA application to the FDA for approval. So it's actually coming on the market, most likely in the next couple of weeks. I thought you would be interested in hearing about that. All right, so Louis Pizero, thank you so much. Great presentation. Really appreciate you taking the time. And thank you very much. And we're gonna go to the wrap up right now. Really thank everyone. I want to thank everybody who's participated today. We actually had great breakout sessions. The quality of the presentations was incredible. And we actually had like a really with it group of judges. And they've actually scored the presentations, and we actually have the winners, and we're going to announce them now. So I think Kristen has a slide. We're going to put them all up there. So we have winners and we have honorable mentions. So the winners are Hannah Matthews, Catherine Ott, Chilachibi Chiziba, Ramon Lorenzo Redondo, Daphne Cornish, Estefani Guzman, Precious Akanyariji, and Sebastian Rodriguez. These are the presentation winners today. Let me go over the honorable mentions. Usman Diallo, Lacey Simmons, Emily Schwa, Becca Kirby, and Varse Sirleaf, Candace Wang, Natalie Comboy, Joshua Togo, Matthew Caputo, and Staffeld and Lena Volpe. So thank you very much and congratulations. And really, I can tell you from Breakout Room 1, it was really very difficult to choose the top winners because the presentations were also good. Okay, just a few other comments here. So again, thanks for joining today. The Havey Institute for Global Health is collecting feedback on today's event and have prepared a brief survey as we consider opportunities to improve our events in the future. As I mentioned, this is our 10th event. The first one we had as the Center for Global Health was initially formed, and that was actually Global Health. It was an entire week. We invited a representative from each of our partner institutions to come here to Chicago for a week. And we had a week of presentations in downtown Chicago in the medical center and the law school, and then up in Evanston and on the campus up there in biomedical engineering primarily. That was really great. We'd like to get back to something like that again once this pandemic gets under control, hopefully. And so anyway, thank you all. We look forward to your comments, and please participate in the survey, which you can find located in the chat box. Okay, thank you to everyone who presented for your incredible work. As I already mentioned, the posters were really great. And if you're interested in viewing the posters from today's session, you can visit us online, and all the posters will be there. The link is in the chat box. So we're extremely impressed, especially under the given circumstances and the virtual nature of this whole event, with all the research and work being done here at Northwestern. We're thrilled to share the selected winners. Congratulations to all of you. And you're going to get more information after the event on exactly what you get for that. And so without further ado, final thanks to Queen Dubé, Maria Odin, and Louis Pizero for their fantastic presentations. We appreciate you working with us on this Northwestern Global Health Day. This concludes today's event, and have a great weekend. Thank you very much.